Welcome everyone to the Orlando GI Journal Club. This is July 5th, 2023. We're currently holding this in Orlando, Florida. Okay, so our first study looked at the effect of prophylactic antibiotics on mortality in severe alcohol-related hepatitis. This was a randomized trial published in JAMA. Severe alcohol-related hepatitis is associated with a mortality rate of 20 to 30% at 2 months, and oral prednisolone is recommended by practice guidelines to improve mortality in these patients. Patients with severe alcohol-related hepatitis are at increased risk of bacterial and fungal infections. However, the benefit of prophylactic antibiotics for hospitalized patients with severe alcohol-related hepatitis is unclear. The aim of this randomized trial was therefore to determine the efficacy of Augmentin, which is amoxicillin clavulanate, versus placebo on mortality in hospitalized patients with severe alcohol-related hepatitis treated with prednisolone. So this was a randomized trial conducted in multiple centers in France and Belgium. This was a double-blind randomized trial. This means that neither the investigator nor the patients know whether they're receiving Augmentin or placebo. They enrolled patients with biopsy-proven severe alcohol-related hepatitis with a Maddrey function score of at least 32 and MELD score of at least 21. Patients were randomized in a 1-to-1 ratio to prednisolone with Augmentin versus prednisolone with placebo. And treatment duration for both prednisolone and Augmentin was 30 days. They followed up the patients for 6 months, and the primary outcome measure was all-cause mortality at 60 days, that's 2 months. So the patients enrolled comprised 142 patients in the Augmentin group and 142 patients in the placebo group. The mean ages were 52.8 in the Augmentin group and 52.5 years in the placebo group. And when looking at the median Maddrey discrimination function score, it was 64.1 in the Augmentin group, 69.7 in the placebo group. MELD score was mean of 24.9 in Augmentin group and 25.8 in the placebo group. Around 3/4 of the patients had ascites, about 12% had encephalopathy, and 21.8% of patients in the Augmentin had received antibiotics prior to randomization, compared to 18.3% in the placebo group. These were the outcome measures. The primary outcome measure was all-cause mortality at 60 days. And as you can see, there was no significant difference between Augmentin and placebo in all-cause mortality, with mortality rate at 60 days of 17.3% in the Augmentin group versus 21.9% in the placebo group. When looking at the secondary outcome measures, the only secondary outcome measure that was significantly different between the two groups was, not surprisingly, the rate of infection at 60 days, which was 29.7% in Augmentin group and 41.5% in the placebo group. However, there was no significant difference between the placebo and Augmentin groups in all-cause mortality at 90 days, all-cause mortality at 180 days, the development of hepatorenal syndrome, the Lille score at 7 days, and MELD score at 60 days. These graphs look at the cumulative incidence of mortality, infection, and hepatorenal syndrome. And as we had discussed earlier, there was no cumulative difference in cumulative incidence of mortality rate between the two groups for all-cause mortality at 180 days, nor the rate of hepatorenal syndrome at 60 days, but there was a significant difference in the cumulative incidence of infection at 60 days, with significantly lower infection rates in the Augmentin group versus placebo. These are the documented adverse events from these two groups. As you can see, serious adverse events were encountered in 68 of 141 patients in the augmenting group, 77 out of 143 patients in the placebo group. The most serious of the adverse events encountered in this study involved hepatic failure, hepatorenal syndrome, incidence of hepatocellular carcinoma, infections, including bacteremia and pneumonia, septic shock, and C. diff infection. Gastrointestinal hemorrhage was observed in 14 and 18 patients in the augmentin and placebo groups, respectively. These are the limitations in the study. It is possible that longer or shorter duration of antibiotic therapy may have been associated with a different outcome. The treatment duration of augmentin in this study was 30 days. Infections were not formally adjudicated, and it is possible that there was misclassification of infections. There was also no formal definition of assessing patients' adherence to antibiotic therapy, so there's risk for bias here, and missing data were not included in the analysis. So the take-home point is that in hospitalized patients with severe alcohol-related hepatitis, augmentin with prednisolone did not improve 2-month survival compared with prednisolone alone. These results, therefore, do not support the administration of prophylactic antibiotics to improve survival in patients hospitalized with severe alcohol-related hepatitis. Our next study is looking at the efficacy of POEM versus pneumatic dilation as treatment of patients with achalasia suffering from persistent or recurrent symptoms after laparoscopic helizomyotomy. So for patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic helizomyotomy, pneumatic dilation is the most frequently used treatment currently. However, POEM is being increasingly used as a rescue therapy. The aim of this randomized trial was to determine the efficacy of POEM versus pneumatic dilation for patients with persistent or recurrent symptoms after laparoscopic helizomyotomy. This was again a randomized trial, multi-center. They included patients who had previously undergone laparoscopic helizomyotomy, who had Eckhart score of above 3 and substantial stasis of at least 2 centimeters on timed barium esophagram. The patients were randomized on 1-to-1 ratio to POEM or pneumatic dilation. It was one POEM procedure, but multiple sessions of pneumatic dilations were performed using balloon sizes ranging from 30 to 40 millimeters in a graded fashion. The follow-up was 1 year post-treatment, and the primary outcome measure was the treatment success defined as Eckhart score of 3 or less, and without the need for any unscheduled retreatment. So 45 patients were enrolled in the POEM group, 45 patients in the pneumatic dilation group. The median ages were 53 and 52 respectively in the POEM and dilation group. The median Eckhart score was 6 in both groups. The most commonly encountered achalasia subtypes were type 2, followed by type 1, and then type 3. The basal LES pressure was 22.7 millimeters of mercury in POEM versus 25.4 millimeters of mercury in the pneumatic dilation group. The column height at 2 minutes was 4.7 centimeters in POEM, 4.3 centimeters in dilation, and column height at 5 centimeters was 3.4 centimeters in POEM group, 4.0 centimeters in the pneumatic dilation group. This was the primary outcome measure of overall treatment success at 1 year follow-up. And as you can see, there was significantly higher rate of overall treatment success rate with POEM at 62.2% versus only 26.7% in the pneumatic dilation group, with p-value of 0.001, with a relative risk of 2.33. When looking at other outcome measures, they found that there was significant lower Eckhart score in the POEM group versus pneumatic dilation group. There was also significantly lower LAS pressure post-intervention in POEM versus pneumatic dilation group. There was also significantly lower IRP in the POEM versus pneumatic dilation group, and also significantly shorter barium heights of both 2 and 5 minutes in POEM versus pneumatic dilation group. When looking at the incidence of reflux esophagitis, there was no significant difference between POEM and pneumatic dilation, although when looking at it numerically, it was higher in POEM at 34.3% versus 15% for the pneumatic dilation group. The main limitation of the study was that the follow-up period was 1 year only, and therefore conclusions on longer-term treatment success cannot be drawn from this randomized trials. Also, this was not a blinded study, with both caregivers and patients not blinded to treatment applications due to the nature of the two procedures involved. And also, we are comparing multiple pneumatic sessions with just one POEM procedure, and it may be a potential source of bias. However, the authors did feel that this reflected real-life practices of pneumatic dilation, where one would perform multiple serial dilations. So the take-home point from this randomized trial is that in patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic Kellis myotomy, POEM resulted in a significantly higher treatment success rate than pneumatic dilation. Therefore, POEM can be considered as the initial treatment option for patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic Kellis myotomy. Our third study is looking at reduced adenoma missed rates with 9 versus 6 minute withdrawal time for screening colonoscopy. This was a multicenter randomized tandem trial from China, published in the American Journal of Gastroenterology. Although 9-minute withdrawal time is reported to be associated with the optimal adenoma detection rate, there are no randomized trials of screening colonoscopies that have confirmed impact of 9-minute withdrawal time on adenoma detection rate and adenoma miss rate. So these authors conducted a randomized multi-center trial composing of 11 centers in China of asymptomatic patients undergoing screening colonoscopy. For this study, the colon was classified into 3 segments: the right colon, transverse colon, left colon, using hepatic and splenic flexures as dividing landmarks. Then segmental tandem withdrawals performed. And so this basically means that each endoscopist for that patient would perform both the 9-minute and 6-minute withdrawals in that same patient. So the designated withdrawal time is equally divided into 3 parts in correspondence with the 3 colon segments that they had assigned for the study. And then after they would examine one segment, they would reinsert and then examine that that same segment, using 9 or 6-minute withdrawal time, depending on the randomization assignment. The reinsertion time and time for biopsies and polypectomy was subtracted from the withdrawal time. So the randomization is not whether the patient received 9-minute or 6-minute withdrawal. The randomization was the order in which the withdrawals performed. So either 9-minute first, then 6-minute withdrawal, or 6-minute withdrawal first, and then a 9-minute withdrawal. The primary outcome measure was lesion level adenoma miss rate. So these authors enrolled 366 patients in the 9-minute first group, and 367 patients in the 6-minute first group. The mean ages was 54 years in the 9-minute group, 9-minute first group versus 53.6 years in the 6-minute first group. They were fairly well distributed between male and female genders. In terms of risk factors, such as smoking, it was fairly equally distributed, 25% in 9-minute first versus 21.5% in the 6-minute first group. First-degree relatives with colon cancer was 3.8% in both groups. In terms of the bowel prep score, there was a mean BBPS was 7.96 in the 9-minute first versus 8.08 in the 6-minute first group. So this was the cumulative detection rate for all polyps was 70.8%. In the 9-minute first group, 64.9% in the 6-minute first group. In terms of adenoma detection, it was 47.5% in the 9-minute first, 45% in the 6-minute. For advanced adenomas, it was 4.9% in the 9-minute and 5.7% in the 6-minute first group. Colorectal cancer was diagnosed in 0.5% in the 9-minute first, and then 0.3% in the 6-minute first groups. So this is the lesion level detection and miss rates. So as you can see, when looking at the number of lesions that were detected in the first withdrawal, in the 9-minute first group, the polyp detection rate was significantly higher in the 9-minute first group compared to 6-minute first group at 1.25 polyps diagnosed versus 0.9. When looking at the adenoma detection on the first withdrawal, it was 0.05. In both groups, that was not significantly different. When looking at the number of lesions detected in the second withdrawal, there was significant difference between two groups, with 0.23 in the 9-minute first and higher in the 6-minute first group at 0.54. Again, the detection of lesions detected in the second withdrawal was significantly higher in the 6-minute first group compared to the 9-minute first group. So when the authors calculated the lesion level missed rate, it was significantly higher in the 6-minute first group at 37.4% versus 15.6%. Again, for adenoma miss rate, it was significantly higher in the 6-minute first group at 36% versus 14.5% in the 9-minute first group. When looking at advanced adenomas, again, the lesion level miss rate was higher in the 6-minute first versus the 9-minute first group at 46 versus 5%, but there was no significant difference in the diagnosis of colon cancer between the two groups. When looking at the participant level miss rate, again, 9-minute first group miss rate was significantly lower, 6.6% versus 18.9%. And the same for adenomas, lower in the 9-minute versus the 6-minute group. And again, for proximal and distal adenomas, although they didn't find a significant difference in advanced adenoma participant level miss rate at 5.6 versus 28.6%. And this difference was not significant difference, although numerically it is higher for the 6-month first group. So the authors then performed a multivariate logistic regression to identify factors associated with missed adenomas and missed advanced adenomas. And for missed adenomas, these variables were significant grouping. So whether they had a 9-minute first 9-minute first versus 6-minute first. And again, miss rate was significantly high. And again, being in the 6-minute first group was associated with significant risk of missed adenoma. Also, having inadequate bowel prep, polyp sizes less than 10 millimeters, flat rather than pedunculated polyps, not having high-grade dysplasia, use of antispasmodics, and not using anesthesia were all associated with missed adenomas and advanced adenomas rate. For missed advanced adenomas, factors associated with missed advanced adenomas was 6-minute group, located in the proximal colon, small size, younger age, and poorer bowel prep. So the limitation of this randomized trial is that this was an open-label randomized controlled trial for colonoscopists, with the same colonoscopist performing tandem withdrawal, which may introduce a subjective bias because the endoscopist knows which withdrawal time they're doing, or that they're being assigned at that particular time. So they know whether they're going slowly or more slowly or not. And therefore this may have introduced subjective bias. The long-term effect of prolonging withdrawal time from 6 to 9 minutes on colon cancer incidence is not known. Studies also conducted in China, and therefore we need to maybe repeat this study in different patient populations to assess generalizability. So the take-home point of this study is that adenoma miss rate and advanced adenoma miss rate are reduced with a 9-minute withdrawal time, as well as improvement in adenoma detection rate in screening colonoscopy. Therefore, 9-minute withdrawal time should be considered as a potential quality indicator to further optimize colonoscopy quality. Okay, so this is the Journal Club recap. In hospitalized patients with severe alcohol-related hepatitis, augmentin with prednisolone did not improve 2-month survival compared with prednisolone alone. These results, therefore, do not support administration of prophylactic antibiotics to improve survival in patients hospitalized with severe alcohol-related hepatitis. In patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic chelysmyotomy, POEM resulted in a significantly higher treatment success rate than pneumatic dilation. Therefore, POEM can be considered as the initial treatment option for patients with achalasia experiencing persistent or recurrent symptoms after laparoscopic chelysmyotomy. Adenoma miss rate and advanced adenoma miss rate are reduced with 9-minute withdrawal time, as well as improvement in adenoma detection rate in screening colonoscopy. Therefore, 9-minute withdrawal time should be considered as a potential quality indicator to further optimize colonoscopy quality. So thank you again for joining us for the July Orlando GI Journal Club. Our next Journal Club will be August 2nd, 2023, 7 a.m. 7 a.m. EST. I hope you have a wonderful day, week, and month. And thank you so much for joining us today. See you in August. Thank you. Bye.